Good morning. Dr. Subramanian is a clinical professor of neurology at UCLA, and she has a long experience dealing with people having Parkinson's disease, and she is certified in integrated medicine. And we are very happy to have her today for this interview for moving along, talking about her recent publication on delivering diagnosis of Parkinson's disease. Welcome, Dr. Subramanian. What was your motivation behind writing such a beautiful article on delivering the diagnosis for people having Parkinson's disease?
So during the pandemic, I had hosted a virtual support group, and we had a number of voices of various thought leaders across the world, sort of connecting our patients living with Parkinson's to each other and to some physicians who were giving advice originally. There were some physical therapists, yoga teachers. We also started to include patients and advocates who are patient voices that are very strong. From that work, we actually wrote a paper around gaps in care, mental health, gaps for women living with Parkinson's. And so, I think that some of the voices really resonated with me around some certain issues that were very important to people living with Parkinson's and how they would want things done differently if they could kind of reverse the time clock and go back to that first day when they got the diagnosis. So there were a few patient voices. Sonia Mathur is a physician, family doctor living in Canada. She has 3 daughters, and she's had Parkinson's for a number of years. She lent a voice, and then Kuhan, who is a advocate in the UK, who makes videos on various topics related to Parkinson's for patients, had also lent a very strong voice. And I think the beauty of the paper is sort of the quotes from the patients themselves that really, I think, hit home for me. So how we started with this paper was just to sort of interview some of the patient voices, get some of the quotes together. We also included a few co-authors that are international and from the Movement Disorder Society, who I met through the MDS. So Annette Schrag, who is a professor of neurology in London, who's done a body of work in the space around self-management for patients and trying to understand from patient voices about how to deliver care to help patients be the agent of their own sort of outcomes. And then Bart Post, who is a clinician, a professor also in the Netherlands, who has been very interested in early onset or young onset Parkinson's disease. So we also have a psychologist on our team, Brad McDaniel. So we brought all of these sort of folks together, looked at the existing data, which is a lot from Dr. Schrag, and then included the patient voices. And that's sort of how the paper, I think, was inspired.
And when we read this paper, it's actually we feel how it is too patient-centered. Yes, you included the patient's voices, and actually it's a paper for physicians and for patients as well. This is what I got when I read the article. And I found the message very empowering for people having Parkinson's disease. And I want you to highlight the important messages from this article.
So I think one important message is that, that message, that first message when you deliver the diagnosis, you have Parkinson's disease, that time frame is actually remembered decades later. People remember, the paint in the room, the smell, the air, everything about that day. And so I think, whatever we can do to bring compassion, to put ourselves in the person's shoes who's sitting before us in our busy lives. And I think, you have a hugely busy clinic, Shema. We all, are running around trying to, take care of things, delegate things, and, get through our workday as quickly as possible. But I think these few moments for this type of patient population, that first diagnosis where you're confirming this diagnosis that will be a lifelong sort of partnership with you and the patient, can really be done poorly, as some of the patients had voiced, or be done, in a way that the patient feels like you're taking the time, that you're really spending, the energy looking at them, in the face, in a quiet space, and providing that sort of extra level of care and compassion, and honestly, hope. I think hope is also a huge piece of what this paper is about. We bring in a paper by Bas Blom and one of his colleagues around the concept of hopeamine, and sort of the sense that we as clinicians, are are really cheerleading for our patients from day one. And so, if we're just saying you have Parkinson's, here's a pill, come back in 6 months, and some patients have even, told us that they've, almost received the diagnosis of Parkinson's like they would have, metastatic cancer or like a death sentence. Literally, that's what they heard. Perhaps it wasn't what was meant to be said, but the takeaway messages from patients in some of these experiences, I think, were really resonating with me about how impactful those sort of words were. So I think, the concept of giving hope and allowing the patient, I think, to take in the diagnosis, making sure that they understand kind of what is being said, writing some things down, providing resources, providing an extra perhaps appointment in 6 weeks to kind of recheck in with the patient to make sure that they're on the right path and feel honestly like they have a team of clinicians, the multidisciplinary team, sort of that are kind of going along the journey with them. And I think that is really important, that it's not just, them alone, that it is them with their clinical team. The paper also talks about the importance of social connection, which has been something that I've been really, I think, cheerleading around, but I haven't spent a lot of time historically before the pandemic thinking about how important, the person who might accompany the patient with them to their visit, who might then be able to support them at home. It might be somebody who's not their spouse. It might be, for a woman, for example, living with Parkinson's, it might be another woman who is living with Parkinson's who becomes their buddy or companion or mentor along the journey, or their sister, or their best friend. So I think, finding that person who brings support, unconditional support to the person living with the disease, they can come along with that person to the visit and sort of help support them after they leave, and for those months while they're getting used to sort of the sense of having this diagnosis, which is definitely, a major piece of news and a major transition point, one of many transition points, I think, for a person living with this disease.
I also like the part about stigma, and yeah, how the self-stigma is affecting the life of um, people having Parkinson disease. And I like the cultural context because it's very important. Actually, uh, it impacts us because the different cultures that we are dealing with, and the misconceptions and false beliefs, all these things that leads to stigma and leads to, you know, how it affects the patient's quality of life. So please highlight this part because it's very important too.
Absolutely. I mean, I think a lot of what we've studied historically and the way that we've learned how to give these diagnoses are from a North American, or a Western sort of image of having, a person with the disease being the one who's, sort of the leader of their team. And in some cultures, it may be, their spouse or their father or their son that really is the person who's kind of guiding them through the medical, sort of world, whether or not we like it. Some parts of the world, the male dominant sort of ability to kind of guide through things is has to be recognized. Additionally, I think the sense that, for example, some women may not come forward because they're too busy, sort of being the caregiver for so many other people. And so they may not take the time to come in for those visits and really need to be encouraged. I know in our culture, the concept of karma, for example, the sense that I did something wrong and that's why I got sick. So, dispelling that. In other cultures, that there's witchcraft that, that has been pointed out in parts of Africa. The patient has been possessed by a witch and needs to be, sort of hidden, or some ceremony needs to be performed to remove sort of this witchcraft. So I think there's a lot of different, angles to this, and in many minoritized populations, there's already a lot of stigma just living in people's worlds as for example, a brown woman, or someone who presents like either of us, right? And we're already kind of going through the world with this. Then you add on a disease like Parkinson's or anything else, it just adds on to sort of that feeling of being othered. And so I think we really have to kind of meet this at the beginning and understand, where the patient is in that whole, sort of cultural context, and help them to understand that the stigma is absolutely normal. The feeling of being other, the feeling of being ashamed or angry, or the host of other sorts of reactions that we put in a figure, that are really from the patient voices. That these are the various sorts of emotions that they feel when they get this diagnosis. And so I think normalizing that, helping to get social support, and then sort of having people to guide them through this sort of trajectory of the disease is really what I think this paper is talking about.
Yes, very interesting. And I like also that in your paper you stressed on the diagnosis is made from the first time, and it's not just a snapshot, it's a process. And also I like what you pressed on the fact that we shouldn't leave the patient with only a prescription and pills, and that's it. We should leave them with plan for the future, with options for non-pharmacological interventions that could even have some disease-modifying features. So would you please talk about this? Because it's very interesting, and I'm interested in this topic
Yeah.
specifically. You know.
Yes, I was excited to hear about your interest in brain health and your training as well. So, yeah, I mean, I think that the patients are hungry to learn about what they can do for themselves. They don't want to be a passive recipient of just coming in once in 6 months for a 15-minute visit, and somebody examines them and sends them home with a pill and come back in 6 months. I mean, I think they really want to have a sense of their own control, their own self agency. And I think when people feel the agent of their disease outcome, they do better. That's been shown in many disease states. And I think part of the medicine is the patient engagement, how they feel, their attitude, all of these things can make a difference. So yeah, absolutely. I think, our senses, and the concept of the wellness task force is to really kind of come up with proactive lifestyle choices that a patient can be given, honestly, from day one, with some vetted resources around, how they can live better. So be that exercise, be that social connection, be that some places of stillness with mind body approaches, getting good night's sleep, diet, these sorts of things can be things that patients pick every day to kind of feel like they're doing something as part of their disease outcome. And so I think that sort of fits this patient-centered approach, the sort of multidisciplinary, sort of multi-pronged approach, with many people on the team also being part of the medicine. So it's whether it's a physical therapist or a psychologist, or whoever the patient may need, a yoga teacher, a religious leader that gives them some comfort. All of these people that we can engage to sort of support the patient through the trajectory of this transition to understanding about their diagnosis, and feeling empowered to move on, with some sense of agency, and then even through the life transitions as this disease progresses.
It's it's valid, especially to our communities in the setting of low resources, because it actually discussed a lot of challenges for the patients and for the physicians and so on. Let's move to the timely diagnosis. So the shift from the early diagnosis to timely diagnosis. So can you highlight this? Thank you.
Sure. I mean, I think in this current environment where we have, many, many things that we can do, genetics, these skin biopsies, various tests that we can do, a sense of a population at risk, REM behavior disorder, patients that we're following along. There are many people that we can give a sense that they may be at risk, or within this time frame may develop motor symptoms. And, this has been discussed in other disease states like Alzheimer's disease and other things, where we are able to move the time clock of diagnosis to earlier. But if we don't have ways to really counsel patients on how they can live better or what they can do with that information, I think sometimes you've now given a person who was otherwise asymptomatic sort of a sense of anxiety and worry about their future. So I think that, we have to be honest about what all of this means. And, I think we still are a very clinical specialty, and especially in places, like where you practice, and even where I practice at the Veterans Administration, we don't have access to all the latest and greatest tools all the time. And it's really me and the patient and trying to figure out what the best move forward is for that person. And so I think, giving early information, if we can't really give ways to live better at the moment, maybe not the right thing for all patients. And so getting a sense of, what the patient wants to know now. Um, and as you know, some patients have said, I just want to know what I have to do tomorrow. Like, don't tell me anything about 5 years, 10 years. Other patients want you to be able to predict 20 years from now what they'll be doing, and how they'll look at their daughter's wedding, and their daughter's like 10. So it's very hard to know, right, all of these things. And so I think we have to sort of work with the patient, get a sense of where they are, where their family is, and kind of help guide them, as we sort of can understand what is right for them at the time. So I think this customization, the sort of cultural context, meeting the person where they are, and kind of getting that feedback of like how they're doing, maybe making another visit, maybe seeing that a certain person a little bit more often, and other people, maybe seeing them back in a year if there's really not much going on, and they're sort of living their best life with all their lifestyle, sort of pieces in mind, and really very minimal symptoms. So everyone's very different.
I would like to ask you a final question about your advice for physicians who deals with Parkinson's disease. So what's your advice for them?
Yeah, I mean, I think that the goal, I think we both love this area, Shaiman, because we think that these patients do really well, and it's a very treatable disorder, and that people live, near normal sort of lifespan in some occasions, and with very full, robust lives, for many patients. And so I think that the sort of attitude of hope, the attitude of being able to keep engaged, and that you're sort of incorporating this diagnosis, but you're not defining your life by it, is important. It's very treatable. We should be, if you don't know how to treat it, get patients to the right place so that they can get the diagnosis confirmed, that they can get on a medicine. I think we both believe that levodopa and dopamine replacement strategies are absolutely reasonable in many patients, and that lifestyle can make a huge difference too. So I think that exercise, diet, sleep, all of these things, and also social connection, I think, is huge, not just in Parkinson's, but I think for all of us, as well as people living with neurological diseases. So I think the brain needs to be stimulated by other people, the sense of touch, the sense of community. We are social animals, I think, as humans. So I think all of these things are key. And so I think giving this diagnosis with hope, giving this diagnosis with a sense of there are people that specialize in this, let me help you get to them, and then giving vetted resources also, so that people feel like they're not Googling things by themselves and then going down these rabbit holes, I think is also pretty important too. Now that we've talked about this, are there any other things that you want our audience maybe to hear from the sort of Egyptian experience, and maybe bring this into your cultural context?
Yes, mostly it's about stigma, it's about delayed in diagnosis, it's about self-prescription, When you talked about comparing self to peers, we encounter this many times in Egypt. Why I have the same diagnosis like this person who comes every week and I see him, but I don't have the same prognosis. I don't have the same pills even. So it's one of our challenges when we are dealing with patient or person with Parkinson's disease, and the stigma. Sometimes the stigma causes the delayed diagnosis and seeking medical advice late in the course of the disease. And also, we don't have access to advanced treatments. It's limited access to advanced treatment. So we are mainly dependent on the levodopa, which is doing great, by the way. Um, and we don't have this idea or this concept of holistic approach for patients. Still, not all neurologists or people, physicians dealing with movement disorders have this concept of having a physiotherapy for patients with movement disorders can help them. So yeah, we started to talk about the value of physical therapy in people with Parkinson's disease, and it has effect on tremors, it have effect on balance and gait and so on. So all these things are barriers when we are approaching patient or dealing with patient. Even the patients themselves, they don't appreciate the effect of physical exercise like the effect of levodopa. So they would like to have pills, and they are reluctant to go to the regular physiotherapy sessions because yeah, the concept is yeah, the person is doing well. So, you know, and still we need to work more on other non-pharmacological interventions like music therapy, dance therapy, because actually I believe in these interventions, and we still have some cultural barriers to using them. And we are trying to like raise awareness about the importance of these interventions, which is not new. It's evidence-based now, and some conferences are talking about the value of dance therapy in Parkinson's disease, music therapy and dancing. So why don't we use these interventions? It's available, and music and dance is part of our culture as well. So why why we are um, not convinced of using them as a line of therapy or treatment for our patients?
Yeah. I mean, I think that sometimes when something's relatively ingrained in your society or community, when it's relatively free and accessible, and then we have this sort of Western framework of, the doctor sitting in a room and giving you a pill and, this is the medicine. I think we forget that a lot of the things that are the medicine, at least to me, are things that are, the sunlight, the grass, the people, the music, for me, music is huge too. So I think we have to really sort of get back to sometimes understanding what brings people joy and comfort and what is accessible to them. Sometimes even if it's $10,000, for a month's supply, it doesn't make it necessarily so much better than something that is, but we put this monetary values on things. And because something is only available in this country, we strive for it. But, sometimes it may not be the thing that would be the best for our patient at that moment. So, but thanks so much for taking the time to talk about this. I appreciate you a lot, Shaima, and the opportunity.
Well, thank you very much for having this time for the interview, and it's always a pleasure to talk to you, Indo.